here to do a podcast in relation to NBC, examination, and we're going to talk about clinical simulations or case scenarios, Joseph.
So they're actually called case scenarios.
So the new term now is case scenario. So those individuals that are taking the boards in January, we're going to be looking at a little bit of a difference, in how the boards proceed. So look, don't get excited about it. Don't get freaked out about it because it's not that big of a deal. I think they did a great job in how they managed this and the direction they're heading in. I actually like it, these scenarios. We're going to break it down for you. We're going to show you a scenario, show you how it works. But for now, if you're studying for the boards and you have a plan for studying information related to all the subject content, which don't worry, we have it here at OT Help Desk, then you're going to be just fine. So we're going to break it down and go through it step by step for you so that, quite honestly, we're just going to go to the website, the NBCOT, National Board for Certification in Occupational Therapy. And we're going to break it down a little bit, and then we're going to do one that we made. So you'll get an opportunity to see that. All right, Joseph. So let's take it away and let's share the screen and get on with this business.
All right, let's do it. All right, so for those of you who are watching on our YouTube channel, you can see the website we have here. And for those of you who are listening to us on whatever format you're listening to for our podcast, we'll go ahead and talk about what it says here. So
wait a second. I just want to mention something. We are not connected with NBCOT, We are not. They want to make sure that we say that, so we're going to say that here. But we're on this website, which is open to anyone who wants to see it, And we're going to go over it because we've spent months preparing for the new case scenarios. We're ready for it. We just want to make sure that you are seeing the information so you're on the same page too. Just wanted to make that clear.
Good point.
Right,
good
go
point.
ahead.
All right, so we have an article title is called OTR Exam Update coming January 2024. And so I'm going to scroll down a little bit here. The main thing that we have going on here is it tells us that we're changing basically from clinical simulation test items to clinical scenario sets, basically, or case scenario sets. And what happens is basically the difference between the clinical simulations and the new case scenario sets is that the case scenario sets now have 6 options to choose from. And you're going to be choosing the best 3 options out of those 6 options there. There's a couple different, as you can see here, if you're on the YouTube page or if you're listening to us on the podcast, there's a couple different sample scenarios that you can go through here that are provided by the NBCOT. Again, like John said, not affiliated with us, but those are available online for you to do to kind of get a feel for how that change in format might be a little bit. It tells you that all candidates who are taking the OTR exam before December 9th, 2023 are going to see the current format of the 3 and 4 choice option single responses, and then the current format of the clinical simulation test items. So again, the change is not going to happen until 2024. So we can link this in our podcast information, and also in our YouTube, the site that you guys can go to. Again, just one more time, it's NBCOT. It's not associated or affiliated with OT Help Desk, but it is something that's publicly available. So what we're going to do now is we're going to stop this screen share, and then we're going to go through, as John mentioned, one of our on the OT Help Desk so that you can kind of get a feel for how this updated format for the case scenario is going to work. So let's go ahead and do that.
All right, so now, let me add one more thing, for anyone who's viewing this, before this is for, a reminder, anyone who is taking the boards before or on December 19th, 2023, you will use the old format, which includes the case simulations, Now, here's the beauty part. We're going to put up our case scenarios in the OT Help Desk, and we'll be putting them up in late October, But the bonus is we're going to keep both of them. So now we're going to move to the case scenario individuals who are taking the test in January of 2024. What year is it, Joseph?
2024.
24. They will be switching to the case scenario. All right. So let's look at the first case scenario example.
All right. So we're going to do one on
when you come in our product, you start the quiz. It's a quiz. Yes. Doesn't feel like one. All right. But it is a quiz. And what you've got is you will see, okay, up here it says the client is a 75-year-old female who has experienced a right hemispheric CVA. Now we'll tag team this, Joseph, like we always do.
All right.
Okay. The client was admitted to the emergency room of an acute care hospital and was subsequently admitted to the ICU. Since then, the client has been transferred to the neuro med surge floor. The OT was ordered to evaluate and treat. During the completion of the screen and occupational profile, the client was able to clearly state her full name when prompted by the OT, and also was able to grossly verbally identify the time of day. The client appears to demonstrate motor impairments of the left upper extremity and appears to have difficulty viewing the OT when standing to the left of the client. Case scenario. Yes, case scenario 1A. As it relates to the OT evaluation process, which of the following are appropriate to perform? Choose the best 3 options. All right, so Joseph, let's tag team this.
All right, so I'm going to read them all out loud because that way, for those of you again who are listening on the podcast, we can kind of talk through them together. So
Okay.
our first,
and just to I want to reiterate something because I think this is why we're doing this. Okay, you know, the idea is that the way this is set up, and having done a number of these now and having helped to create them, okay, the way it's set up, you have to remember you have the option now, which is nice, to go through all of them and pick which 3 you're going to keep versus the old case simulations, which were different, okay, where you didn't get to do that. So this is the nice part about it, and this is why I like the wingman. We have a wingman concept in the OT help desk, which teaches you to think through step by step by step, and our wingman works perfect, okay, with this process. So let's go down through it. Again, the case scenario, okay, as it relates to the OT evaluation process, which of the following are appropriate to perform, and choose the best 3 options. So go ahead and read through them, Joseph.
all right, so we got our first one there, and it states complete a range of motion and strength assessment of the client's extremities. So that makes sense to me here. I know that with someone who has a stroke, it doesn't necessarily tell me exactly where the stroke occurred, except it tells us that it was a right hemispheric CVA. It doesn't tell us where the area of occlusion was, but I know that when we're thinking about the common sequel of effects after a stroke, typically impaired strength is going to be one of those. And so definitely I want to go ahead and complete a range of motion and strength assessment of the client's extremities. I want to do that for both of them to make sure, and that way I can compare their affected extremity. If they do have impairments in strength, I can compare it to their unaffected extremity. So definitely completing a range of motion and strength assessment of the client's extremities is definitely something I want to do. So I'm going to say yes for that one.
Okay. So what about assessing for the presence of receptive aphasia?
Yeah, so the next one, like John said, is assess for the presence of receptive aphasia. And so again, there's a couple reasons that I'm probably not going to go with this one here, and I'm sticking with my wingman for one of them. It told me that this person was a right hemispheric CVA, and typically we know that when we're going to see aphasia, is typically going to be more of a concern with left hemispheric CVAs. And so that's something to think of as it relates to our diagnosis. And then also with this one, it told us in the case scenario information that she was able to clearly state her full name when prompted by the OT. And so that indicates to me that this person, there's nothing that indicates that they would have difficulty understanding what the OT was telling them. It sounds like they were able to participate in some of those orientation questions. And so that is something too that, would indicate that I probably don't need to pick this one here.
Okay. Complete a vision screening. I like it.
Yeah, absolutely. I think that I do want to go ahead and complete a vision screening, especially with right-sided damage after a CVA. That's typically when you're going to see visual spatial impairments. And so again, sticking with my diagnosis here, thinking about the hemispheric damage there being the right-sided, I do probably want to complete a vision screening. So that's one that I'm going to go ahead and go with as well.
All right, good. Complete the Barthel index to assess functional performance. Don't you do that?
Absolutely. This is something that is very OT related, of course. We want to do something that's going to address their functional performance, their ADL abilities. And so the Barthel Index is a really good one, especially because it sounds like right now we're in an acute care hospital. And one of the good things about the Barthel is that you don't necessarily have to do performance-based. You can actually do through interview or through your clinical judgment to help fill it out. So it's not like you have to do a full performance-based assessment of every ADL. That would be a little bit difficult to do in the acute care setting, but the Barthel Index should be a good one to help measure their functional performance that you could do that's feasible for that setting too.
So what's kind of interesting is he's going to check this one, and we currently have 3 that are checked, which means 3 yeses. And quite frankly, the last 2, if you're that confident, okay, the last 2, it shouldn't matter.
It shouldn't, but we still need to go though, and we still need to go through them.
Nice, yeah, good job. Make sure you do them. Yeah. Don't get cocky. All right.
We still, we still want to stick with our process of elimination and really make sure that we're, looking for the wrong answers just as much as the right answer, because we want to still eliminate the wrong answers and make sure we know our right ones that way.
All right. So are you going to recommend splinting of the left upper extremity?
So the case information told us that this person did appear to demonstrate motor impairments of the left upper extremity. And it might be something that we would do, but it's part of the intervention process. Remember, it tells us up here that it says, as it relates to the OT evaluation process, which of the following are appropriate to perform. And so if this was the intervention process, potentially, but since we're in the evaluation process still, I'm going to get rid of that one.
Okay. Report to the nurse that the client appears to demonstrate intact cognition based on their orientation status.
Okay, so this one too, I'm not a huge fan of either, because all we know about their cognition is that they were able to fully state their name and they were able to grossly verbally identify the time of day. We don't know if they were oriented to the place. We don't know if they were oriented to the situation. And maybe they do have impact global mental functions, but maybe they have some deficits in more specific mental functions like attention, or, maybe some of the higher level executive functions. And so there's just not really enough information to say that they have intact cognition based only on their orientation status. Since again, we don't even know, we have to think about A and O times 4. We only know 2 of those. So I'd get rid of that one as well.
All right. So we're left with 3. Complete a range of motion and strength assessment of the client's extremities, which is logical. Complete a vision screening, okay, and complete the Barthel Index to assess functional performance. And I'm going to go back real quick and just read what the case scenario said. It says, as it relates to the OT evaluation, which of the following are appropriate to perform? All right. So let's go to the answer.
Sure, let's go ahead and press. And again, if you see here on our YouTube video, we're pressing a button that says check, and then it's going to show us whether or not we got them right. And then if you scroll down on the page, it'll kind of give you the rationales for why they're correct. And we're going to read through some of those here. The first one, which was complete a range of motion and strength assessment of the client's extremities. That was something we needed to do.
Hold on, stop. I need to ask you a question.
Sure.
So when I'm doing this, right, which is really cool, I like to be able to see the response over here as to the reason why. Should I be taking any kind of notes on this? Because this kind of scrolls, right?
Sure. And
because then if it says the client's left upper extremity demonstrates 1 out of 5 movement proximally and 2 out of 5 or 2 minus distally at the wrist and hand, how should I be thinking about what I should be doing here?
I would definitely jot down some notes about some of the key information, just in case. A lot of the times, if there is something that they provide you, especially about any deficits they have, at least, again, we can't speak for the NBCOT, but at least in our case scenarios, it usually is going to be something that will probably be relevant, moving on in the scenario. So I would take some notes about the deficits they give you, anything about the practice setting that they're in, anything, relating to that nature. I would take notes on.
Okay. So anything relating to a deficit. Okay. Anything relating to the practice setting, like if they move from one setting to the next, that's always critical. And then what was the last thing you said?
Just said anything of that nature that you think would be relevant to that.
Okay. All right. So go ahead, Joseph.
So again, the first one, complete a range of motion and strength assessment of the client's extremities. That tells us that the client's left upper extremity demonstrates 1 out of 5 movement proximally, which we know is trace, and 2- out of 5 distally at the wrist and hand. So I'm automatically thinking that they have better distal strength, of course, than proximal. We have assessed for the presence of receptive aphasia. Like we talked about, the case information told us that the client was able to clearly state her full name when prompted by the OT. There didn't appear to be anything that would indicate that they were having difficulty understanding what the OT was asking of them when the OT prompted that, which might indicate the receptive aphasia there. And then we also know that aphasia is also more of a concern with the left hemispheric damage. So I'd get rid of that one like we talked about. A vision screening, it tells us that oculomotor tracking and visual fields appear intact, but the client requires cueing to track to the left of midline and appears to be inattentive to the left visual field. The client's deficits appear to be related to hemi neglect. And so if I'm thinking in my head here, automatically formulating, thinking about some potential questions that I might be asking future parts of this set here, I would be thinking that this person, has damage that is going to be related more to attentional problems. It's not a vision deficit. Remember, if someone has hemi neglect or hemi inattention, it's not because of damage to the visual pathway. It's because of damage, it's because of attentional deficits. And usually it's related to parietal lobe damage of the brain. But again, it didn't tell us exactly what area was occluded, what area is affected here in the brain, but we do know that this is not a visual deficit. It's more of an attentional deficit when they have the hemi neglect.
Okay.
All right, the next one, the Barthel index, we definitely want to do that one like we talked about. Excuse me. And it tells us that the client requires moderate to maximal assistance for most ADLs. The next one recommends splinting of the left upper extremity. So again, we're still in our evaluation process, and we know that we first need to assess to determine what deficits we have before we make recommendations for our intervention. So no with that one for sure.
Makes sense.
And then our last one, I'm sorry, I keep coughing there. Report to the nurse that the client appears to demonstrate intact cognition based on their orientation status. Again, it only told us that they were grossly oriented to person and time. It didn't tell us if they were oriented to the person or the place or the situation. And so we can't make that determination whether or not their cognition is intact until we do further assessment. And it says here that the OT further assessed the client's cognitive status, and they appear to demonstrate poor safety awareness, judgment, and impaired insight into their deficits, which, fun fact, John, what is that called?
Anosognosia.
Anosognosia, that's right.
And that is?
Poor insight to your deficits.
Poor insight to your deficits. Got it.
I was just seeing if he was paying attention there.
I was starting to fall asleep. Okay.
Got to keep him on his toes.
All right.
All right, let's head to the next one here. And let's go ahead and read it. John, do you want to read it?
Sure. The client is a 75-year-old female who has experienced a right hemispheric CVA. So if it's a right hemispheric CVA, okay, then we're going to have problems on the left side.
Right.
Got it. Okay. Based on the results of the evaluation, the client's left upper and lower extremity are hemiparetic and hypotonic, and left scapular musculature appears paretic. The client appears to demonstrate neglect to the left visual field, confirmed by the line bisection test. With this pattern of impairments continuing during the completion of functional activities, with the client making no attempt to self-correct or attend to the left side of the environment. All right, I know what I'm thinking. Okay, based on the Barthel index, the client requires moderate to maximal assistance for the completion of most ADLs due to the noted deficits, along with impaired balance and postural control. The OT has now completed the evaluation and will begin the intervention process with the client, which will include splinting. So case scenario 1B, as it relates to the intervention process, which of the following are appropriate to perform? Choose the best 3 options. Stop right there. I want to talk about something very brief. Many times when you're reading a question like this, a scenario, okay, what happens is students will read them too fast. So I know it seemed like I was taking a lot of time to do this, but I'm not. What I'm doing is a first run read. And the way that works is this way. When you read something, there's a reason why they put periods and commas in there. Okay, there's a reason. It gives your inner voice versus your outer voice, the one that's reading the question. And no, it doesn't have to be out loud. It can be reading the question. But when you read the question, allow your inner voice, the one that says, hey, I got this, okay? Allow the inner voice to catch up. When you do it, it will help you, okay, with processing a question. But you have to practice it, because if you're reading fast, there's a really good chance you're going to miss something. Now I'm going to read this again because I already messed everybody up. So let's read it again. So based on the results of the evaluation, the client's left upper and lower extremity are hemiparetic and hypotonic, and left scapular musculature appears paretic. What's paretic?
Weak.
Weak. All right. Weakness. The client appears to demonstrate neglect to the left visual field, confirmed by the line bisection test. With this pattern of impairments continuing during the completion of functional activities, with the client making no attempts to self-correct or attend to the left side of the environment. That's not good.
No.
Based on the Barthel Index, the client requires moderate to maximal assistance for the completion of most ADLs, moderate to maximum, due to the noted deficits, along with impaired balance and postural control. The OT has now completed the evaluation and will begin the intervention process with the client. And by the way, it's going to include splinting. So the case scenario 1B, as it relates to the intervention process, which of the following are appropriate to perform? Choose the best 3 options. Now I want to make a mention here, because I'm not saying you have to do this, okay? But there's a lot of different ways to approach a question. And one of the things that you could really do right off the bat is read down through them and immediately get rid of it if it's not an intervention. I'm not saying that's going to happen, but I'm just offering that as one attempt.
Suggestion, sure.
Yeah, a suggestion.
And kind of,
Go ahead.
oh no, I was just going to say,
go
kind
ahead.
of like the previous one that we had where it was in the evaluation process. We
Right.
had the one that was an intervention, and that was how we knew we could get rid of it.
And you can immediately get rid of it. It's just another way to do it. I like the rolling one, the way you did it, where you say, look, this is an intervention, okay? And again, which of the following are appropriate to perform? Because if you think it's appropriate to perform and you keep it, and all of a sudden we have 2 at the end and there's one there that looks more appropriate, well, then you can get rid of the first one that you did. Right?
Absolutely.
Okay, so let's do it, Joseph. So provide the client with a resting hand splint for the left upper extremity for full-time day and night use for joint protection. Do you like it?
I don't like that one.
All right.
I like the idea of the resting hand splint for night use, but this is where I was talking about some of the things that the information that you get from the previous one might be pertinent to what we're looking at now. It told us that they had some movement of the upper extremity. I think it said it was 1 proximally, so trace proximally, but 2 minus out of 5 distally. And so if I have them in a resting hand splint all day and night, they're never going to have any opportunity to try to progress their strength in that arm there. So while they can be more supervised during the daytime, I think it's probably a great idea to have the resting hand splint on at nighttime for joint protection, but during the daytime when they can be more supervised, I think it's probably good to encourage the use of that extremity during the day, and then more so use the splinting at night for joint protection and, alignment of the joints during that time.
Yeah. And the other thing too is it when you're dealing with a CVA, Okay, what happens is that we also know that many times it starts off hypotonic. Okay, and then what it does is it progresses, okay, into more of a synergistic pattern or spasticity. So when that happens, what you get, example, is shortening, okay, of the in terms of the tissue of the muscle and the tendon in that area. So what you want to do in this particular case is splinting is going to also prevent shortening of the tissue at nighttime and allow it to maintain, because what you want to be able to do is use it after you take the splint off.
Okay? Absolutely.
So what about position the left shoulder in a sling during activity and to rest to promote joint protection? You like that, Ike?
No, I'm getting rid of this one too,
I hate
because
slings.
I do too. And remember that a sling places you in the position of contracture, because it places you in internal.
Like this.
Boom. It places you in
right across the front.
It places you in internal rotation and adduction, which we know is the position of contracture. So, definitely don't want to do it in activity and at rest. And there are other different types of supports that you can use if they truly need that. Let's say that they have just a flaccid extremity. You can use some different other types of support. Like there's something called an Autobach, or there's something called a Give More. These are not advertisements for these products. It's just ones that I've used before that put them in a better position than an actual sling does. So
Makes sense.
I'd get rid of that one again, because it just sounds to me like that's going to promote contracture.
All right. So far we didn't pick any.
Not yet.
We've got no's on the first ones. Let's see what the next one is. Engage the client in weight bearing through the affected upper extremity in a seated position while completing a functional reaching task. Boy, that sounds like OT. Okay.
Yeah, that sounds.
I
like it. That sounds great to me there. We know that weight bearing it can help promote some neuromotor return. It can help facilitation of that upper extremity there. It can go, and the great thing about weight bearing is it can go through all the joints distally, all the way proximally to the scapular musculature, which we know is impaired.
Ain't nothing like neuromotor return, which is basically a different way of saying proprioceptive input to the joints and to wake them up, and hopefully to promote sarcomeres through the actin and myosin chain. Oh, I love that stuff.
Exactly.
Okay. So, all right. So we got one. We're keeping that one. Well, we're in good shape, because guess what we know right now? Okay. We know we're picking 2 out of the next 3 for sure. So engage the client in assisted range of motion with particular attention to external rotation. Oh, sounds counter to the sling, doesn't it?
It does. And that one makes sense to me too, because one of the, like we talked about, the position of contracture can be internal rotation. And so we want to make sure that we're definitely assisting them with that range of motion, or facilitating the external rotation, to make sure that they don't develop a contracture there of internal rotation.
Just remember, you put them in internal rotation, and the shoulder ligaments, everything is going to shorten, and it's going to play right into a flexion synergy pattern, which we really don't want to do that. All right, so we got another. So let's go to the next one. Okay, instruct the client to perform supervised self-assisted range of motion of the left upper extremity to approximately 90 degrees shoulder flexion. So that'd be right here. So right here. I like that, especially if they're supine.
Yeah.
What do you think?
I am liking that 90 degrees there. And the reason I'm liking that is because we have to think about scapulohumeral rhythm, and I'm sure that rings a bell to everybody there. But remember that your scapula, after you get past 90 degrees, it's going to be moving equally with the humerus. So from 0 to 30 degrees, the scapula is not going to be moving at all. From 30 to 90 degrees, you're going to see, I believe it's 1 degree from the scapula to every 2 degrees at the humerus. Is that right?
You got it.
And then past 90 degrees, the scapula is going to be moving equally with the humerus, with the movement there. Right. And so what happens is, it told us that they had left scapular musculature that was weak and hypotonic. And so if they go above 90 degrees, what's happening is you're risking impingement of the shoulder there. It's just going to be ramming that supraspinatus tendon into the acromion. So we want to make sure that we're limiting them initially to 90 degrees until they get a little bit more scapular movement, or unless someone is manually facilitating the scapula into upward rotation. It didn't tell us that was going on here. So I like that one there. So I'm going to go ahead and I meant to click the ones that I like. I'm going to go ahead and click this one, which was engage the client in weight bearing through the affected upper extremity in a seated position while completing a functional reaching task. I'm going to click engage the client in assisted range of motion with particular attention to external rotation. and instruct the client to perform supervised self-assisted range of motion of the left upper extremity to approximately 90 degrees shoulder flexion. And what do we got, John?
So
got one more.
We got one more. Let's read it and do due diligence in case there's something that pops out.
Sounds like
okay. Provide the client with a self-assisted range of motion exercise program for the left upper extremity. Limit it to 90 degrees elevation for independent practice outside of therapy sessions.
Oh, this is tricky.
It is tricky. So the last one, let me just reiterate, was instruct the client to perform supervised self-assisted range of motion to the left upper extremity to approximately 90 degrees shoulder flexion. Well, that's interesting. Well, maybe we should get rid of two of them because they're similar.
No way.
You don't think so? Oh yeah, people, don't play that game here.
Let's compare. Okay? Let's compare them.
Compare them first.
So one of them, they're basically saying in both of them that we're teaching them a self-assisted range of motion program. Left upper extremity limited to 90 degrees elevation, which is absolutely appropriate. But the choice before this that we chose said they were doing it supervised, and the question or the option below says that they're doing it for independent practice outside of therapy sessions. That's the difference between the two, is that one of them is going to be supervised, one of them is going to be independent. And we know that it's not appropriate for them to do this independently yet. It told us before that they have safety awareness impairments and they have judgment.
And anosognosia.
And no sagnosia. And so in my mind, I think if I give them this and tell them to do this outside of sessions, they're going to be really improperly handling their upper extremity. They're going to be handling it willy-nilly. It's going to put it at risk for, injuring the joints there when they're handling the upper extremity if they don't have appropriate supervision. And so even though it's appropriate for them to do the self-assisted range of motion limited to 90 degrees elevation, that's perfectly appropriate. I don't want them to do this independently outside of therapy sessions because of their poor safety awareness. So we have to think about it from a joint protection perspective.
I like it. And I like the thought process. And one of the things that's really going to be important with these case simulations is how you approach them. Okay. Not just checking answers before you really think through the process. So we checked the three that we thought, okay, but that last one, okay, it could have been tricky and some people might have picked it. And now you got four. Okay. And you got to get rid of one of the other ones. That's the danger to this process when that happens. So try to make sure, okay, that you're going through them. And I like the way we're doing it. I like that. Okay. Some will say, hey, read them all first. Okay. And then go back up through. I like the idea of it's fresh in your mind what the scenario has suggested. So as you're doing it, build on the scenario with each one of the answers. And at least make your first attempt, hey, I like this or I don't like it. And that way there, if you run out at the end in the bottom and you've got them all, you're in good shape. But if not, you play the game that we just played. What is the game? The game is in standardization testing. The most important thing is not to guess. Yeah, let me reiterate that. People who start telling you to guess on these scenarios, they're wrong. Okay, period, wrong. If you don't know something and you're on the exam, when you're on the exam, okay, that's okay. You may have to guess. I'm sorry. You may have to. And then you can use what they're saying. But no, we're practicing right here. So if there's something you don't know, smart thing to do, go look it up. Because the more you take at guessing, okay, the more your brain's going to remember your guesses. Okay, right. Don't do that. Now, I think we did enough here. Okay, there are 4 of these. We're going to stop here because we've already been taking up a lot of time. But let's just reiterate, okay, that if you're taking the test, okay, on or before December 19th, 2023, you're not using this format. Do not use this format. And quite honestly, I wouldn't practice with it, okay, because I don't think it's a smart move. I think you should be using the case simulations, right? Not the scenarios, okay? Because it's going to confuse students. And I've already seen it happening, okay? So that's something to stop in its tracks right now. Don't do these if you're taking the test before December 19th. It will confuse you, Okay. We at OT Help Desk will be putting these up in mid to late October. Okay. And they'll be available. Okay. But again, if you're taking the boards before December 19th, on or before, don't use these. Okay. And I'm prefacing that because I'm not, unless you're the kind of person that can be really open, okay, with this process, that makes sense. Okay. So, and you know, the idea is to really stay focused on where you're at in the process. And we don't want to be adding an extra layer to the process for those that are taking it in 2023. But you guys in 2024, you got to have at it and you got to begin to think about this process. And you know, I believe that this is a great change to the process, and I understand that this is moving towards helping students in the area of accommodations and things of that nature. And I think it's wonderful for our profession to be doing that. Okay. Last thing I want to just talk about here is just to mention OT Help Desk, because in OT Help Desk, how do you get to the case scenarios, right? In the OT Help Desk product, the way it's set up is we layer everything cognitively. Okay, so in the beginning, you go through and you pull our PDFs off when you first start our product. And our PDFs are written in the NBCOT domains. So you're looking at, okay, all the way up from the beginning of the diagnosis, the etiology, the prognosis, all the way through to client factors, all the way through to the assessment and evaluation process. And it's nice because you can read them through, and then it evolves, okay, through that case simulation or case scenario, as we've discussed, and then up through the advanced level questions. And when you hit the advanced level questions, you're going to be getting a higher level question, what we refer to as a 5-6, which is the highest level that you need to be preparing, okay, when you're taking high level tests. Okay, we're going to say high level test. We don't want anybody telling us we're telling you you have to do something for NBCOT. We're not going to play the game. Okay, most important thing is you have to position yourself to reason at a higher level, and that's what we teach in the product, and that's what we practice in the product. Also, okay, we do open sessions and topic sessions. Joseph, talk a little bit about our open sessions and how that might help with this kind of a scenario, kind of like what you and I just did, right?
Yeah, the open sessions are pretty much, I mean, they're very similar to what we just went through, which is where students come and they are able to read different questions, and then, they kind of work together on answering them through a clinical reasoning process. And we get a lot of good feedback on those, especially because students like to hear other people's perceptions on a question. They feel like they appreciate hearing other students' clinical reasoning processes. There might be things in another student's clinical reasoning process that they can integrate into their own process that they hadn't thought about. But it's basically the open sessions at the OT Help Desk that are offered are basically all about learning how to clinically reason through a question.
And they're every day, okay? And sometimes we record them and put them up, okay? But for the most part, you have access to open sessions Monday through Friday. And then we also do another type of a process, and that's known as the topic sessions. Joseph, what's your thought on the topic sessions? Because I developed the concept of what I do. Let's have you explain it.
Yeah. So basically the topic sessions go beyond, the topics that are covered in them might be the same as the topics that are in some of the foundational content, but it kind of goes beyond looking at it from a knowledge-based perspective and kind of takes it one step further to where you take this information and you look at it in a little bit of a different way. Again, it's similar to the open sessions in that you're trying to build a clinical reasoning process. So in the topic sessions with Dr. Connolly, basically what happens is, again, you're going to go through a specific topic. Maybe it's splinting or something related to hand and upper extremity. Maybe it's burns. Maybe it's pediatric development. But the way he's going to go through it is going to challenge you to think of it in a little bit of a different way, more so in relating to how you can clinically reason through anything in relation to the topic.
And it's really interesting because students who have failed the boards, okay, and come into the product, I'm going to give you an example of how that works, because the idea is to go into a product and study everything again. No, you don't want to do that if you've already taken the boards. Okay, you have to step back. You've got to do what's referred to, okay, as sifting. Okay, sifting is to go through information and identify what you know and what you don't know. And at the same time, no guessing. All right. So as part of that, we've developed that into this process. And when we're doing topic sessions, we're rolling through information, and I'm taking information that you've already learned. Okay. That's the point. Okay. And I'm bringing it to a higher level of clinical reasoning, as Joseph mentions. Students really who need that. Okay. Really important for students to begin to think at a different level. And the last thing I'll leave you with is well, two things. One, I want to just mention that what happens if you come into a product like ours, okay, and you're already pretty good at answering test questions, well, then you don't need to go to the open sessions or topic sessions. You need to focus on the lessons and get them done. Okay. And we use a 75% rule. If you're scoring below 75%, which anybody who failed the boards is, okay, then you need another tool in your shed. That's right. You need to consider the open sessions and the topic sessions. For students who are scoring 80% and above, 75 and 80% and above on the test questions, okay, in our product, I will just say in our product, okay, you don't need to do the extra stuff, because you're already pretty good at doing that. The last thing I'll say is that, as the very last thing, is we've got these 40 lessons, which have all the content that we mentioned. We've got these open sessions and topic sessions that are live. And then we have a 10-day process. And our 10-day process has been developed, okay? And what happens is when you get to about 14 days, you're going to contact the office, and then you're going to meet with me. And what we're going to do is we're going to talk about your 10-day process. Our 10-day process has been developed. Okay. Is it secretive? Well, sort of. Okay. Because the bottom line is we spent years and years developing it, and it works. Okay. So come learn about our 10-day process, which helps the student to build endurance. And it's interesting the way we do it from start to finish. So we believe we've got a great product here. Okay. We believe that we're on it. We've been on it for things like the scenario. We keep developing, we keep researching, and we keep doing it with evidence-based practice information. So what do you think?
I think it all sounds good to me.
All right. Well, it's been great seeing you, and we'll look for you in the next podcast. Thanks for coming, everybody.